Hello, this is Robert Casanova, and I'm sending you this video to get you ready for the end of rotation OSCE. At the end of the session, what I really want you to be able to do is to discuss the reasons for the actual OSCE, to describe the components of the OSCE, to discuss the key components of a good encounter, that's the patient encounter, and also the components of a good note. So, why an OSCE? First of all, it's the only way that we can actually have direct observation. Medicine is too opportunistic for us to be able to see every student encounter the same patient and compare how they do with a standard. We also want to reinforce good behavior, and you'll see when you get the end of rotation OSCE notes from ExamSoft that it'll tell you what you're doing well, and it'll tell you what you need to work on, which is the way that we correct poor behavior. Also, it prepares you for Step 2 CS. The problem is that a lot of times that's all that the medical student is concentrating on, but I want to tell you it also prepares you for internship. A lot of times people say that we're teaching towards the test, but if the test is what I actually want you to do when you're an intern, then I feel like I'm preparing you for life. So what makes up an OSCE? First, there's a standardized patient encounter, which is the patient interview. What the patient does is they assess your interpersonal communication skills. Are you establishing rapport? Are you professional? And then also, are you thinking critically? Because remember that this patient interview is the key to your note. Then there's a patient exam, and that's how we assess your exam skills. We also assess your professionalism and how you progress through the exam, and of course, the critical thinking. Finally, there's the differential diagnosis. This is how we assess your medical knowledge. And a lot of times students will tell me they got the 98th percentile on the NBME, but they didn't do well on the OSCE, or they didn't do well on medical knowledge in the actual clinical skills assessment. And so I have to tell you that this is how we assess critical thinking from your interaction with patients, not with scenarios or not with multiple choice. So what are the components of a good encounter? Well, you always have to introduce yourself. Very important. Hi, Ms. Smith. I'm student Dr. Sam Hargis. Ask the patient how they want to be called. Do you want to go by Ms. Smith or do you want to go by Sally? And then start with open-ended questions. You have to realize that the open-ended questions will only yield so much information from a standardized patient because they really do want you to get the information from them. I always tell people that if the diagnosis has the word pain, ache, hurt, or anything else that sounds like that, you should do old cards or OPQRST. Finally, you have to have a plan. What I mean by this is from the minute that you see that differential diagnosis on the sheet outside the door, you have to figure out, what do I think is going on with this patient? So for the physical exam, one of the key components that's just a freebie is to wash your hands. There's a lot of discussion back and forth as to when you should wash your hands, but if you go to the Clinical Skills CS website, you'll see that it's very explicit. You want to wash your hands before you examine the patient. It's very awkward to walk in and wash your hands before you shake hands with the patient, before you talk to them, because it seems standoffish. So go ahead and introduce yourself, shake their hands, do your interview, then wash your hands before you examine them, and you may also want to do it at the end. Explain to them what you're doing. So, Ms. Smith, I'm going to listen to your heart and lungs. Pretend it's a real patient. One of the things that I see when I view these videos is that a lot of times when you're auscultating the chest, you're not holding the stethoscope in place long enough to actually get a heart rate or to listen to an entire breath sound. So listen to the heart long enough that you can actually tell what the heart rate is, and then listen in the right places. The point of maximal impact, the PMI, is not above the breast. You're going to actually have to lift up the lady's breast or have her lifted up. So make sure that you do that. The other thing is to do the proper level of the exam. Going overboard and doing a full abdominal exam when they're complaining about a footache is not the right thing. But if you think they might have appendicitis or an ectopic pregnancy, you have to do all of the necessary components. That means you have to inspect, you have to auscultate, you have to percuss, and you have to palpate. Finally, don't do unnecessary procedures. We don't really count off for that, but the clock just keeps ticking while you do these things that do not contribute to the diagnosis. When you go and do CS, they actually do take off for doing unnecessary procedures. One thing that we often forget is that you have to explain to the patient what is going on, and you have to use layman's terms, not medical terms. It's really easy when you get into the swing of things to say, we're going to get a quantitative HCG. They don't know what that is. Tell them we're going to get a pregnancy test. We're going to get some lab work. We're going to get a urine sample. We're going to go to a chest x-ray. Tell them what you think they may have. Again, use layman's terms and avoid using the word cancer. So what are the components of a good note? First of all, you have to have the chief complaint. Nobody will ever fault you if you write capital C, colon, my heart is beating really fast, something along those lines. Second, you have to have the opening statement, and that is generally specific to the specialty that you're using, to the specialty that you're seeing. So in obstetrics and gynecology, we always use age, gravity, parity, LMP contraception. So you'd say chief complaint, right lower quadrant pain, history of present illness is an 18-year-old white female, gravida 0, LMP 2 weeks ago, on oral contraceptives who complains of. In internal medicine, they have their own way of doing it. Find out what that way of doing it and do it. Finally, have a differential diagnosis in mind and make sure that you follow all of the possibilities all the way through the note. So if you think that the headache could be a migraine, but it also could be meningitis, make sure that you ask migraine questions and meningitis questions in your HPI, that your review of systems shows that you're excluding or including those, that your physical exam has those components, and that you follow up with them also. While on the clinical skills exam at the end of this year, you'll be doing a very focused history and physical. For us, we want you to do the thoroughness questions. That means that you have to do the past social history, family history, surgical history, and allergies, and all of those things. And don't forget the specific components to the specialty. You know that in OB-GYN we like to have that menstrual index, the sexual history, and in pediatrics we like to have immunization, so don't forget those. Other things about a good note, vital signs. This is another freebie. Comment on the vital signs. Don't just write them down. If the blood pressure is 90/50 and the pulse is 140, she's hypotensive and tachycardic. You'd be surprised how much insight the vital signs can give to you. Finally, there's the physical exam. Include all of the pertinent components and use a language to let us know what you did. I'll show you a little bit more about this on the next slide, but basically, how do I know you inspected? How do I know you're percussed? So here's an abdominal exam. So for inspection, I would say no scars or skin changes. Auscultation, bowel sounds present in all 4 quadrants. Percussion, no dullness on percussion. Palpation, no masses or tenderness. So you can't assume that we know what you're doing. Make sure that you're very specific if the chief complaint entails the entire exam. Finally, for the differential diagnosis, choose 3 possible diagnoses. Sometimes it's only 2. Make sure that you're addressing it the entire way, from your HPI to your review systems to your physical exam. Tell us why you think it's number 1 and not number 2 or 3, based on your history and your physical exam. That means you have to have been asking questions to justify your answers. For your plan, tell the patient what you're going to do next, and tell us what's next. Lab, imaging, EKG, IV, antibiotics. We don't necessarily want the dosing or even the names of the antibiotics, but we do want to know what your plan is. So here's a sample note. The chief complaint is getting harder and harder to breathe. So if your differential is congestive heart failure, COPD, and asthma, you have to make sure that your HPI and your review systems and your physical exam include components so that you can justify it. Here's a sample note from that, and what I've done is I've highlighted in yellow all the things that have to do with congestive heart failure. So you see that there's yellow in the HPI, in the review of systems, there's yellow in the social history, in the vital signs, in the physical exam. Then COPD is in green, so I have it all the way through. And this just gives you an idea that I'm really thinking about these. And finally, asthma is in blue, and again, it's in every single component, whether it's a positive or a negative. Here's another sample, pain in my side. So what's your differential if this is a 50-year-old male with left lower quadrant pain? I would think diverticulosis, small bowel obstruction, maybe inflammatory bowel disease. And on my note, the yellow is diverticulosis, so I have yellow all the way through. For small bowel obstruction, I have green all the way through. For inflammatory bowel disease, again, blue all the way through. I don't have very many things to go with that because I guess I ran out of things to think about. One thing that you have to remember is that doing these exams is all about timing. You're going to have 15 minutes for the interview. That means that when the monitor or proctor says you can enter, you can flip over your clipboard, you can look at the chief complaint, you can make your outline and then walk in, whatever you want to do, but you literally have 15 minutes for the interview. If you finish the interview in 12 minutes, you can walk out and start writing your note, but once the proctor says your time is up for the interview, you have to walk outside and start writing your note, and then you have 10 more minutes, okay? It's very important that you plan accordingly. One of the things that I like to tell people is that when they give you the 5-minute warning, where do you want to be? Do you want to be doing your physical exam? Do you want to be explaining to the patient what's going on? Where do you want to be? So that pretty much wraps it up. If you have any questions, don't hesitate to call me. Best of luck.